So it's my great pleasure to introduce Helen Parker from Pinnacle Ventures. And Pinnacle is in the Midlands Health Network in the central part of the North Island of New Zealand. So she's going to cover the design elements of healthcare homes and what they've told us about the future of primary care and her whole implementation experience. I mean, Helen's got a really terrifically insightful background, being both a researcher, a former nurse and a practitioner. She's been also, I can see, supporting some of the Australian developments in healthcare home. And I know she's a really energetic presenter with some terrific practical insights. So I really look forward to hearing what you've got to tell us, Helen. Thank you.
Thank you very much, Leslie, and thank you, Sarah, for asking me to do this presentation. Good morning or good afternoon, depending on which time zone you're sitting in. And I think energetic by Leslie means that I have a lot to say and can run over time. So I'm just going to set my stopwatch so we don't do that today. Yeah, in order to be able to share some of the learning that we've had from supporting practices to just transition from traditional good general practice to what we call over here the healthcare home model, I'll spend a little time talking to you about our model, as it's quite different from the Australian healthcare home programme, much more extensive and a much more radical change of how general practice delivers its services and interacts with other services around it. So just for some clarity there. And as Leslie said, happy to take any questions at the end. Okay, I now have a problem, so I can't do my slides. There we go. So as well as doing that, I'm also going to share some of the outcomes that we've gained internally and also from the Ernst & Young independent evaluation that was published in April. And then for the last 15 minutes or so, focus on pulling out some of that key learning and also some of the policy implications, which I know Leslie will also touch on in her session on the 15th of October around those key areas. And firstly, just for those of you that don't know our context, we are a Pinnacle GP-owned network, which is actually about 30 years old now. It's covers about up to about nearly 500,000 patients, and as Leslie said, we cover as you can see, that middle bit of the North Island. Pinnacle started looking at the need for developing a new model of care, both to preserve the good things about general practice and not to lose them, but also to ensure that it's sustainable over the next decades or so and for the next generation. And over the last 8 to 10 years has been designing and developing that. We now have 16 practices delivering a fully established model with more in the pipeline, but actually it's gained momentum across New Zealand, and now we've got over 130 practices doing it. I mean, our first practices started in 2012 after a couple of years of designing and looking at what was happening globally in terms of primary care and what was delivering what outcomes. And really our healthcare home model is putting together that global evidence base, but making it New Zealand sensitive. And our healthcare home practices are a mixture of urban and very rural sites, most of them privately owned. Some are our own practices, but most of them are privately owned. We have a dedicated change management team to support practices and a Power BI data dashboard, which enables them and us to monitor progress and actually make intelligent decisions about change based on data. And because of the growing momentum across New Zealand, we've now developed the National Healthcare Home Collaborative, which has set some national standards for the model, which really is just saying what's different about a healthcare home practice over and above traditional good general practice. And essentially what we've been trying to do is to look at the 4 domains within general practice, how a general practice manages acute demand, how it manages the care of patients who are their highest needs patients, not necessarily highest clinical risk, but the highest needs. So they're typically the patients that require a lot of care and care coordination. And we look at that through a proactive care lens and look at how that can be improved, how a practice delivers its routine and preventative care, and how it does all that very efficiently as a business, because obviously a sustainable general practice service needs to be both a profitable and a sustainable business. And then, having redesigned general practice internally, we look at then how that practice then interfaces with specialist care in the hospitals and in the community, intermediate care, and particularly self-care that patients deliver every day for themselves. So the three areas we focused on is actually transforming the care model, and I'll talk to you a little bit about that, transforming how that is delivered, and then transforming the care connections between patients, their family, and all providers that are involved in their care. And we're often asked, well, what are you actually trying to achieve? If we've got really strong, traditional, good general practice, what are we trying to achieve? I'm not going to go through all of these, but we're trying to look at how can we value patients' time. If you look at traditional general practice, actually patients waste a lot of time. And sometimes that's employers' time too, of going into a practice, waiting for appointment when they didn't need to. That could have been managed online or by telephone. It's also about actively promoting and supporting activated consumers. Now that's slightly jargonistic, but we do know that consumerism and particularly the opportunities of technology are driving, and particularly in the younger age group, but not only the younger age group, consumers are quite tech savvy and wanting to become more involved, and indeed are doing so in their own care. We're also wanting to shift general practice from being largely reactive to as much of the care as they provide being proactively planned, and through a population health focus too. So for example, a lot of general practices, not all of them, run mini ED type models, first come first served. If you're the first person to get through on the phone in the morning, you get the slots of the day that are available, and hard luck if you couldn't get through. And yet you might have been the person that really needed to sit in front of a GP or nurse that day. So one of the things we do is re-engineer how a practice manages that acute demand and put control back into the GP's seat by doing things like clinical phone assessment of people wanting a same-day appointment, to ensure that those that really need to see a GP or nurse get to be seen, and those that need some clinical care but don't need to be seen that day or don't need to be seen at all can have some online or telephone advice do so. And actually creating a sustainable integrator within a local health system. One of the problems that you read, particularly in research papers, is that it's difficult to identify who is accountable in primary care and community services for a patient's overall patient experience and how they consume health and social services. It's very difficult to pinpoint either one person or one agency. And we've nailed our colours to the mast, really saying we believe that sustainable integrator should be general practice and capitalising on particularly our enrolled health system. But actually making sure that practice has got the services around it that it needs to help with that and is resourced internally to do that. It's also about, recognising that things that we're suffering from across developed health systems of a reducing primary care workforce in some areas, and particularly our rural areas, and improving the working day for clinicians particularly, so that it attracts a younger workforce. And of course ensuring best value for our health dollar. So what's different about a healthcare home practice compared, as I say, to a traditional good general practice? Well, I'm just going to take you through a few of the key elements. I haven't got time to go through everything. Our website details are at the end of my slides if you want to go and get some more information. But the first thing that's different about healthcare home practice is routinely being offered a choice of consult mode. Now, obviously, that has to be clinically appropriate, and it has to be a patient choice thing as well. So for our healthcare home practices, they will offer patients a face-to-face appointment on a one-to-one. They'll offer patients a planned telephone consult, which we do they do generally charge a co-payment, as they would if the patient visited the practice. An email consult, if that's appropriate, or actually our practices are just moving into delivering shared medical appointments and group consultations for patients. And we're finding that for some patients, these are delivering much better clinical and social outcomes than we've had with them either not engaging with general practice or the traditional one-to-one practice-based consultation. So there's a choice of consult mode. Secondly, referring back to that proactive care for the highest needs patients within a healthcare home practice, there'll be a systematic review of actually who those patients are, so that the whole clinical team needs them. They're flagged on to the patient management system, and actually there's a process of putting together quite a comprehensive care plan, which is clinically based and also patient goal-based, and wrapping an interdisciplinary team approach around those patients. And actually the practice leads on that process, but obviously it can't deliver all of that care. But actually one person is identified in that care plan as being the person responsible for coordinating the care of that patient. Thirdly, I should say, one of the things we do to support a practice is help them to get the best clinical value from each clinician. So ensuring that GPs are only doing things that you need a medical qualification to do. Nurses are only doing things that you need a nursing qualification to do. Pharmacists are only doing things that you need a pharmacist qualification to do, and so on. And when we first start working with a practice, we often find that particularly the nurses, but also some of the other clinicians, are doing quite a bit of work in the practice that you don't need a nursing qualification to do. So we put in a healthcare assistant, we call them medical centre assistants, who often take off some of that light nursing load from the nurses, and actually that frees them up to focus them more on the high care needs patients. So we do that first. It's often when we go into a practice, is the nurses saying they're very, very busy, so it'd be really difficult for them suddenly to start doing a lot of extra work for care coordinating and care planning for high needs patients, and yet these are the patients that need it, and we know that there's benefits to both those patients and the system for them doing so, but we need to free up the clinical time to do that. So most practices will spend time agreeing what that best clinical value looks like. And also, obviously, to make the care connections better, and how many years have we all been saying this, all the providers and the patients and their family need to have sight of the same health or care plan and be able to edit it and update it so that anyone who's interacting with that patient can see a live care plan that is up to date. So we've spent quite a lot of time and working with Ventrues Technologies to introduce a new patient management system that will enable that to happen, which is system agnostic, and any provider can look at it if they choose to do so. And also the patients have more control, particularly over their care plan. I think the other thing that we've been quite systematic, but actually late to the game too, we've only really started doing this in the last 18 months to 2 years, is actually supporting patients to be able to contribute more to their care, but also to their practice and how the practice delivers services, and also looking at healthcare in a wider sense. So we set up practice patient participation groups. That's something that's very prominent in the UK particularly, where a group of patients can meet regularly with the clinicians and staff in the practice to look at how services are delivered, and particularly from a patient perspective. And we've had some really good outcomes from that. It's still quite embryonic in nature, but practices are starting to make that work. We've also developed and established recently a consumer panel where patients from a healthcare home practice can sign up to either receiving one-off surveys from us about a particular area of health. It might be about health policy, or if, for example, we've just done a survey on the use of patient portals, and also to patients who don't use a patient portal. And we've had a phenomenal response to that, actually. We have the happy or not devices in each of our healthcare home practices that allows a practice to take the temperature of patients in terms of how they felt about the service that they've received that day. Obviously, it just gives them a green, red or amber light, but it alerts them to a problem, and that's happened, and practices have changed on the back of that. We have a patient experience app feedback, and we've done some co-design as well around various elements of the model. Now, what makes the healthcare home work? Well, as I said before, having a patient information system that allows for a new model of care has probably been actually essential. The patient management system that most of our practices had just could not support the new model. We also needed to, and I'll talk about this in a minute, about mobilising primary care out of the general practice building. So we needed clinicians, but particularly the doctors, to be able to access that patient management system wherever they are, from an iPad, for example, whether they're delivering a service, in the forests or up at the Marais for us, for our Māori patients. And then actually what makes the healthcare home work is patients having access through that patient portal to both email consultations, but also test results, their health record, being able to make an appointment, but particularly being able to email their clinical team. And, just going back to what I was saying right at the very beginning about patients, general practice struggling to meet its call demand. We find our practices have a huge call abandonment rate, particularly at peak times in the morning, and particularly on a Monday morning. So we developed a patient access centre. It's like a call centre, but it's much more sophisticated than a call centre. And the people that are answering the calls are an extension of the general practice team and dedicated to that practice or a group of small practices. And the patient feedback is fantastic. They answer calls very quickly and resolve 70% of them. What we can do in some practices, not all practices, is I was going to talk about estates, so I'll flip back, is re-engineer the working day to value the patient and clinical time. So the templates, particularly, for example, the GP templates, will look quite different in a healthcare home practice. They'll have a bit of time for set aside for managing those email consults. There's no point adding emails if they're just going to be sitting at home in the evening doing them. So there's time in the working day to do that. There's time to be doing that phone clinical assessment and triage, telephone triage. There's time for planned telephone consults, and then also time for the planned face-to-face. And the way we manage to make that happen is to re-engineer everything else in the practice that frees up GP time to be able to do that, and to move some of the face-to-face appointments that they would normally see either online or to other professionals. And then what the new, of course, a new IT system can do, where you can take the IT system and the patient information out with you on a laptop and a Mariah, allows you then to take general practice out of that general practice setting and into different places. And our practices are starting to do that. In fact, I'm going to share a couple of patient stories with you for that. So just coming on to the outcomes then, and I appreciate I'm racing through this a little bit. It takes time for a model of care to embed. It takes time for outcomes to be generated and evaluated and researched and data to be collected. And I'm always a bit hesitant about areas who want to implement a new model of care and then think that they're going to see great outcomes, particularly on the impact on secondary care use very quickly. And I think some of our learning has been that it probably takes at least 3 years to be able to show a practice or a group of practices real significant outcomes. There's some very quick outcomes you can get, particularly by doing the phone triage or clinical assessment. But we've started now to be able to credibly show improvements in the patient experience, improvements in some clinical outcomes, reduction in secondary care utilisation, and actually, as the Ernst & Young report commented, that the highest impact of the model seemed to be on our Māori, who have got a disproportionate poor health outcome profile, the elderly, and those with the highest need, and also improved GP recruitment and workforce satisfaction. A couple of patient stories then. Some of our practices in Taupo, together with that team that we've wrapped around those practices, have started to take services out of the practice into the marae, and actually up to some truckers who meet every morning at 6 a.m. And most of those truckers are Māori and completely disengaged from traditional general practice, have not set foot in those general practices. We've applied the evidence base from putting community health workers with some training alongside a clinical team. And Shane, who you can see in that picture there with the T-shirt on, has been on a very significant health journey himself, going from morbidly obese and staying at home to now actually being a community health worker for us, working with the team, working with GPs and going out to where those patients are. And just a couple of stories from that. So George was one of those truckers, largely disengaged, hadn't set foot in a general practice for years, but had got shortness of breath. And when he started to engage with Shane particularly, we found he'd got high blood sugars and symptoms of diabetes. Actually, Shane was able to encourage him to attend a group consultation, which started actually at 6 a.m, where all the truckers met. And by working with him, sharing his health story, gaining his trust and confidence, actually moved him into a group consultation that was a little bit more formal in one of our offices, but not in the general practice, where he was able to then link George with a dietitian, with an exercise consultant and a nurse practitioner. And George his blood sugar levels have dropped. And I think most importantly, he's engaged now in about his health. He's joined a water walking exercise class, and as a result of that, he's now able to walk for much longer distances than he could before, which, as he said, has improved his quality of life no end. And I think he's the type of guy who would have never got into general practice. And the same with Milton, who's 56. Again, Shane worked with him about trying to help him engage with not health services, but in his health, and that if he achieved better health, he'd be able to do more. And again, he started coming to some group consultations at the truckers' stop, and also at an exercise swimming class. And he's lost weight, he's lowered his blood sugar levels, and again, he's now feeling as though he's got his life back. And we're also doing those sort of group consultations on the marae and reaching people. There's a woman I was talking to the other day who hadn't been in a general practice for 40 years and is now going for a health checkup. I'm not going to go through this. You can look at this when you look at the slides early, but this is Dr. Hayley Scott talking about, she's a GP owner in Te Aroha, a small practice of about 5,500 patients in a fairly rural area. And about how the healthcare home model has made such a difference both to the workforce and particularly to the GPs, but also to their patients. And actually, for the first time, they've not had to use locums for 2 years, even when Hayley herself was off sick due to a fractured leg. And actually, the owners have been able, who are actually quite burnt out before they started the model, have been able to take some time out. But it's taken a good 6 years for them to get to that point. As I mentioned earlier, the Ernst & Young evaluation was quite positive, even though some of the areas for a healthcare home, as I say, are still quite embryonic, but actually did show that a significant proportion of acute need is being successfully dealt with outside of hospital compared to non-healthcare home practices, and that it had a high impact on the people that we really want it to have a high impact. So they did a comparison of healthcare home practices with some control practices of about a population of 80,000 patients. This isn't a comparative outcome, but what they did say by trawling through all our data for 6 months of the healthcare home practices that 62% of patients who had requested a same-day appointment were managed safely and appropriately without a need for a visit that day. And we know from our own data that about 30 to 40% of those didn't need to come into the practice at all. They could be managed by telephoning that quick triage call or in a planned consultation. And some of those did need to come in but didn't need to come in that day. And that does two things in terms of a model of care. Firstly, it enables the GP and patient to have a conversation on the phone, so the GP has already taken the history. So if the patient does need to come in, that consult is much more managed. The GP typically will say, I don't need to see you today, I need to see you on Thursday, but let's have a blood test or an x-ray or something before you come in. It's already taken the history and has already started to plan that consultation. Or they may need to see a nurse or the pharmacist. Or indeed can manage that need on the phone without the patient needing to come in at all. What that then does also is free up the acute slots that the GP has that day for the people that really do need it. And the GP then can control when they see those patients and who they're seeing, as opposed to a traditional general practice where generally it's the patient and the receptionist that are booking out the GP time. Now, what the Ernst & Young evaluation said that actually comparatively you were 24% less likely to attend ED if you were Māori. You were 32% less likely to attend ED if you were over 65. Now that's quite a significant figure for us, because one of the things we want to do is prevent people having to go to ED in the first place, but then have a risk of being admitted once they're there. And actually, if you're enrolled with a healthcare home practice, Ernst & Young was saying you're 20% less likely compared to the control group to be admitted to hospital for unplanned care. However, what they did say, which was very interesting for us, was that for the healthcare home practices, compared to the non-healthcare home practices, there was comparatively more ED presentations for the 0 to 14s. Now, obviously, that wasn't good news for us, but it was good news that we actually knew about it. We've had quite a few discussions as to why we think this might be, and we're just going back to have a look at the data in a lot more depth to see whether it's putting the GP phone call in between a parent being able to bring their child down to the surgery that's then putting them off, or despite some GPs saying they talk to parents of sick children who are very happy they haven't got to come down, but we do wonder if they're actually feeling more anxious because they've not been seen and so going off to ED. And as you know, 0 to 14s are free in general practice and ED here. It's not a cost issue, so we're looking into that as to whether we need to change the model. So lastly then, some of our key learning and policy implications. From a patient experience perspective, and again, I won't go through all of these on each slide because I haven't got the time, but I'll just pick out some of the key ones. I think some of our learning, particularly in the implementation process and before a practice makes the changes, so for example, like you'll speak to your GP before you get a same-day appointment, and over 60% of our patients speak to their own GP with a call back, is that you cannot over-communicate about the changes you're making with your patient so that they fully understand why and what and how it's going to impact them before you make the change. So we have a number of ways we do this, but one is a community forum that patients can attend where the practice team will explain the changes they're making and importantly why, and most patients actually get it. We've also found that actually with the call management, because obviously this is a radical change for practices to remove all their calls to an off-site call centre, albeit the staff are trained really well, and I've actually spent time in the practice, so get to know the practice and get to know the practice staff, and they get to know the frequent callers as well. We thought, you know, patients as a whole may not like that change, but I have to say the predominant feedback from patients is getting their call answered usually within about 30 seconds, first time by a person, not an options selector, who can most of the time manage what they're asking for. About 30% of the calls go back to the practice because it's appropriate for a clinician to speak to patients, they trade that off for not speaking to their reception staff. Sometimes that takes a while for practices to understand. It also frees up the reception staff to just manage the patients that are coming in through the door. They're not stressed out by the phones and that, maybe practice teams tapping on the shoulder for something. Patients change behaviour when the rationale, as I said, is clearly explained to them. But obviously this takes time. If you've had custom and practice as a practice of patients just being able to pole up and sit in the waiting room, and somehow clinicians will speed up to make sure they can fit them in, it takes time for patients to realise that actually that's not the best way to run that service, and doesn't always mean that the right patients are getting from to GP. So it does take time to transition to that. And as I said earlier, the consumer panel and the patient participation groups has been very, very well received by patients. But I'd say the most positive feedback we get, particularly just on the healthcare home model, is particularly working people and the elderly about not having to go into the practice unless they really need to, or they want to go and see a GP, and getting their calls answered. And I guess one of the questions we're asking here is, do we need a real national health consumer strategy in forums such as the one that you have in Australia that can collect a more collaborative, collective consumer and patient voice, which we're starting to do with the consumer panel, but do we need a national one? And then leadership and change management. Well, I could spend 40 minutes just talking about this. You know, we often say to our practices, particularly ones embarking on the healthcare home model, we appreciate it's difficult to rebuild and redesign your plane when you've still got to fly it. You know, people in practices are busy, they're doing their working day job, and therefore to actually change quite radically the way they do things, the way they work as a team, the way they work with patients is a big ask. And I think having one of our enablers we've learned is, first of all, having a consistent narrative and vision as to why this is important and why it will be better for them as a practice, why it will be better for them as clinicians, why it will be better for the patients, and why it's better for the system overall. And actually we found it's critical for them to have that skilled change management support from people who really understand general practice and what it's like to work in general practice, but also understand change management and how you do it well. It's really critical, we found, for particularly the leads in the practice, the GP lead, the practice nurse lead and the practice manager, to have some time out and some headspace to think about the change, think about how it's going to work in that practice, and plan and continue supporting the practice team. So we fund that up front. That practice headspace is absolutely critical. And we've also found the healthcare home peer groups that we run, where we bring practice teams together to share, review and support each other, is critical for support and keeping the momentum going. But also it's helped us to develop the model. We've learnt with each practice what's worked, what hasn't worked, what could we do better. The practices have shared how they've tackled things, and that all contributes to us continually refining how it's done. And it takes time to embed, as I said earlier. It takes time for those outcomes that particularly the funders are keen to see to actually be demonstrated in the data. And I think that what we've also found is because practices get into a different headspace as to actually how could we really do things better, it's starting to innovate other things within general practice. So for example, 4 of our practices that have gone into the model that were previously quite competitive with each other in the same locality have started to look at collectively delivering town-wide services, and that wouldn't have happened unless they'd gone through the model. So we've been asking some questions though. You know, have our early adopters signed up, and how do we incentivise those who are not natural adopters? I don't think we'll ever change the die-hard cynics view, who are firmly rooted in this is how I've always done it and this is how I'm going to continue to do it. But actually there's some that are sort of bridging the fence, and do we need to incentivise them to take that up? Do we need some more national professional leadership to support new models of care? And actually, how are we growing experienced change leaders required to support actually at-scale transformation. We struggle to recruit those people, and it's not just us, I think that's across the country. I guess also, and this may be a bit more of a personal plea, particularly from funders, shifting the focus away from what's the impact going to be on hospital care to actually what's the impact on prevention, the patient experience, the social capital gained by people not having to take time out of a working day, and the quality, the clinical quality and the service quality to patients, and not just a focus on, well, we'll support it if you're going to save us some ED and hospital admissions. And then we've learned a lot about the funding and organisation of primary care. You know, we work on a partially capitated model here in New Zealand, which is helpful. And also the practices obviously are funded through some patient co-payment too, and some other small streams of money. And initially the patient co-payments that practices receive when a patient visits the practice can seem to be an inhibitor to patient care, but actually when a practice has worked through, and we've done some financial modelling of making the whole change, it does start to cover itself off. So for example, if you've got nurses doing less time ordering clinical supplies or sitting on the phone doing recalls, they can spend more time face to face. But there does need to be some investment in primary care to spend time doing triage where you may not want to charge the patients a fee. We found that larger practices are better able to separate out delivery of acute care and planned care more easily than much smaller practices. And we found that separation is really, really helpful, ensuring that planned care is done well and not interrupted, and actually there's the right workforce to manage acute demand, particularly if a practice runs a deliberate walk-in service. We've also found that interdisciplinary teams around a population of 30 to 50,000 are, for us at the moment, delivering our best outcomes. And interestingly, it seems to be, this is the model that's emerging within the UK, and also some of the primary care medical home model in the States, that actually that population is small enough for people to know each other, to support a much better relationships between teams, but large enough for the critical mass for some of those professions that you need. And we're intending to roll that model out across Pinnacle. I guess one of the significant things that we're finding, and we haven't got an answer to yet, so if someone wants to give me that in the Q&As, I'd be grateful, is that spending that time with patients, spending longer time with those higher need patients that practices typically don't have the time to spend, putting together a really comprehensive care plan, is actually exposing a level of unmet need that primary care is neither funded for or equipped for, without a lot of services around it. And that's placing some of our clinicians particularly in quite a difficult position. We're trying to do what we can by developing those interdisciplinary teams, but some of it is a real level of social unmet need that I guess most clinicians know are there when they're consulting with patients, but actually being transparent to bring it out into the open means that then you really need to address it. And so they're struggling to do that. And I guess some of the questions around that's raising, particularly in terms of policy, is that, you know, should funding and commissioning be driving greater sector convergence through the health hub type model that's emerging in some areas to ensure that practices have got services around them, so the true interdisciplinary team can approach, and particularly including the social workers in our teams are invaluable for supporting some of that. Do we need to think about a radical new funding for primary care to take into that picture, you know, the need for practice teams to spend longer with some of those patients, which currently capitation and the co-payment doesn't meet. And I guess some of the questions for us with new entrants into the market, picking off low acuity care, offering them very quick and convenient video consults, you know, does that mean we're going to see a challenge to our practice enrolment and therefore capitation here in New Zealand? And my last couple of slides about the workforce, the learning that we've had on the workforce is that doing that work up front about getting the best clinical value from GPs and nurses and other clinicians in the team is actually leading to a much greater job satisfaction for some of our clinicians, re-engineering their working day so they're not on the treadmill of lots of face-to-face in the mornings, lots of face-to-face in the afternoon, having to fit all the patient paperwork that comes out of those at lunchtime or in their own, own time at night is really helping us in terms of retaining and attracting our workforce. We're finding that our workforce is not generally equipped and skilled for that proactive high need care, particularly some of the nurses. We're having to put in a lot of time to retrain them or train them on what does a really good comprehensive care plan look like, and there's no formal training available. And there's a lack of formal training here for in New Zealand anyway, for doing really good virtual health consultations, whether it's by email. How do you manage email? How do you shut it down when it's not getting out the remit of what's manageable on email? We're just not geared up systematically and nationally for these new workforce models. And are we training clinicians to understand and act on actually all the streams of data that are now available, whether that's coming from the hospital, whether it's coming from the practice itself, or whether it's coming from patients themselves, from their smartphones and their wearables? Are we training tech-savvy clinicians? Are we training clinicians who feel comfortable working with the quality assured apps that are out there that will support patients in their patient management? And how do we generate system level workforce development plans that are focused on a new model of care? And I could talk for much longer about that. And then of course there is, coming to the end, the opportunity that technology provides, not technology for its own sake, but how technology can be an enabler to better care and more convenient care for patients. Ernst & Young saw in their evaluation that the use of portals was significantly higher in our healthcare home practices, and that's because supporting patients to use a portal and for it to make sense to them and relevant to them at the time that you're trying to sell it to them, in inverted commas, is a much more systematic process in our healthcare home practices, and therefore the traffic coming in from patients is a lot higher. Over 45s are our highest users of the portal, although we do know that Māori are underrepresented in that. And we do know by that offering online care is increasing capacity with our existing workforce. And again, what we've seen, and I think there was a research study, but I can't remember the name of it now, that was saying that, and we're seeing some of this, that patients and our GPs some of them are reporting this, that patients are coming in having got to grips with some health technology. We know that some of it's not so good, but some of it is very good. And actually the practice teams are behind. They don't know about it. They don't know how to use it. And we're seeing that, patients are becoming keen to engage in it much more quicker than our clinicians are able to respond. And that's a piece of work that we're looking at about how do we train, as I say, our workforce to do that. But our clinicians working in the healthcare home practices are seeing real opportunities for mobile working, seeing that they can actually take their skills and expertise out of the practice, and particularly where those patients are that are not engaging with traditional health services. And typically they'll be the patients that could do with seeing that GP or that nurse or that pharmacist or nurse practitioner most. And some of us have been saying here that does that mean in the future, and actually one of the GPs in our healthcare home practice was saying this to me, that he can see his practice in the future just being for clinical procedures only, and actually he can practice anywhere in the community and can probably save his patients from the very north of his patch travelling to see him. It takes them 40 minutes. There's some questions that's raising then is, and particularly for us in New Zealand, I don't know about Australia, will we have a coherent national strategy for technology that both supports the workforce but also the patient's desire for receiving health services in a new way? We need a national strategy and a coherent one that makes the links between primary care, hospital care and NGOs and other people providing care. I guess in New Zealand, we're just going through a health sector review. Will that be radical enough to ensure that we can mainstream tech-enabled care, and it'll be funded, and that the training will for clinicians will also be funded. So that's me. There's some contact details if anybody after the Q&As has still got some burning questions or want to know more information. Our healthcare home website, we try to keep updated, and that has most of what I've been talking about on there. Thank you.
Thanks, Helen. That was a really kind of richly layered presentation of all the issues underway. I've been checking the Q&As, and I can see the questions that are coming through are really so how do you actually do it questions. So there was a question asking about how do patients choose whether they're going to get a phone consult or a email one or a face-to-face. Some questions about funding as well, and whether you get how that's worked. You've flagged that as an issue in terms of, obviously you get more funding for face-to-face. How have you decided what to charge for the online or telephone consultation? So maybe a couple of kind of really in the roots questions about how do you do it?
Yeah, so I'll see if I can remember all of those, Leslie. Yeah, I didn't have time and chose not to go through our implementation process because of the other things that I wanted to say. We have, and we've learned a lot doing this, we have quite a streamlined process now to support practices to make the change. First and foremost, it's getting owner buy-in. One of the things we've learned that is less the owners really want to make the change for themselves, they'll find it difficult to keep the momentum and lead their practice to make the change. So that's one of the first things we do, just check that the owners and all of them are really bought into that, into changing their model of care. We then financially model it for them. We model making some assumptions about how they're going to change their care. We model the next 3 years for them so that they've got some confidence that it's sustainable for them in the practice. We haven't had a healthcare home practice that's lost money yet from adopting the healthcare home. Equally, it's not a model to make money. And then we have a series of workshops where the practice team come together with us. So we bring the learning from some other practices, and over that 2 or 3 workshops, they put together their own implementation plan. And that's what I'm saying about providing. We fund some of that clinical time for them to do that, or sometimes we do it on a Saturday, so the whole practice team can be involved in all of those. And they come up with their own implementation plan that covers those 4 domains I spoke about. And then they have a live action plan, and that action plan will say what they're going to do, when, who's going to do it, and what support we're going to provide them. In terms of the funding, we provide some one-off funding to support some of the establishment costs, like the time out of the practice to do the workshops, like for a short period of time, 6 months or so, for the leads to have some headspace during the week to manage the change in their practice. And then we also uplift the capitation a little bit, not much for those practices, in recognition of the additional virtual care that we're doing. And in some areas of New Zealand, the DHBs are contributing to that.
So that's a great answer to another question. Also, someone was interested in the practice headspace time and how much thinking time and over what time frame would you suggest. So you've outlined nicely the sort of whole implementation path there. Would you have any other comments on time frame?
I think it varies from, as you'd expect me to say, from practice to practice, depending on what skills they've got in the practice to lead the change and what support they need externally. We'd say typically, probably for the first 6 months, someone needs, we fund the equivalent of a GP session once a week. Now, how the practice spends that money is actually up to them. Sometimes it funds practice manager time, practice nurse time, or GP time. For about 6 months to a year, depending how confident they are about making the change and how they're progressing. But actually, it's those quarterly peer groups where they come together as practices and share and learn. We look at the data together about what their outcomes are, and each practice has an action plan. and we refine the action plan at the peer group. It's like those sort of things that keep the momentum going and give them the time to think about what they're doing and how they're doing it. And the one thing we advise on is for the pace of change not to be too ambitious, particularly in the winter months when you have a lot more acutes patients to see, but equally not to be so slow that you don't see the change. You know, set your patients up for change and it doesn't really happen and staff can't see it happening. So there's a real risk then that you just revert back to the traditional model. So it's difficult to say roughly, but I'd say about the equivalent of a session a week combined between, you know, the practice manager and the nurse lead and the GP lead and other people in the practice.
That's good advice. And then I'm curious, just this first question, if you're a patient, how do you choose your type of consultation? Do you get it, you ring up, obviously, and then you get offered those choices, or you say what you always want?
Yeah, no. Yeah. So, and I think that the thing for us, it's about at the time that the patient needs the care, and particularly for follow-ups, it's about, that's part of the clinical consultation. Okay, so we need to follow up. Can we do this by telephone? Can we do it by email? Or do you actually need to come and see me again? So that's typically how it would be done within a follow-up. I don't think many of our practices, they discourage using emails for an acute presentation.
Yeah.
So, you know, the patients, you know, if you're ill, don't email us. You know, give us a ring, and then you'll be able to speak to a GP, and we'll talk to you about what the next step will be. So in that first, it's not really triage, it's much more clinical assessment and treatment. The GP speaking to a patient will say, actually, I can't do this in a minute. Either we need to speak longer on the phone, let's book a planned telephone consult, or actually we need to see you, come in today.
Right.
So
no,
it's done at the time of the clinical conversation, and we think that's the most appropriate way to do it.
Great.
But often patients will generate it themselves. So if a patient's used to emailing their GP, they might flick them an email to say, I'm a bit worried about this. They know they shouldn't do it, you know, it's best not to do it if they're feeling ill or acutely ill. But, you know, if they've got a query, they'll email, and then the GP can respond and say, I can't deal with this by email, you need to come and see me, or let's book a telephone conversation.
That's really helpful. And then there's a question here, how do you see this could be translated into the funding model in Australia? So that's a big ask for you to answer. I was curious how we've ended up with the same name meaning different things.
Yes, I know.
So,
and that has, I guess from our perspective, that's been slightly irksome because people do think the two models are the same, and hopefully people in Australia who are watching will see how this is very different, both in terms of the model design, but also in terms of how we implement it and fund it. And I won't say any more than that.
Yeah.
It's tricky, isn't it, in the fee-for-service and the bulk billing model in Australia. And certainly in my work with some of the PHNs and talking to people in practice, they do see that as a real barrier developing new models of care. Having said that, I think there's still quite a lot. I think there's still quite a lot you can do, as long as, you know, there's recognition that there needs to be some investment in the change management process. So there needs to be some investment to give people in practices time out to think about what could be different, how it could work, what does the data tell us, and what changes can we make. And I think probably where that didn't happen as rigorously as we do that over here before changes are made. But certainly I think we're going through a health sector review, which includes a review of how primary care is funded, and I think we're having these exact same conversations. You know, patients are demanding a different model of care. They're demanding much quicker, convenient care that isn't default face-to-face, having to go into the practice, wait, having to see a clinician and come out again. And we've got to recognise that in the funding model too.
That was my reflection, thinking about actually patients will be demanding this longer term, and that's probably where it's going to come from, is people having to adapt to the demands coming through. Yeah.
Yes, but if you look at our move towards group consultations or shared medical appointments, where a GP or another health professional can meet with 8 patients for an hour as opposed to 4 patients for an hour, and actually we're seeing some really good outcomes for patients, both clinical and social care outcomes, with that peer support and having the GP time for an hour rather than just the 15 minutes. And actually that works for the business model, because you're getting 8 co-payments for an hour where you'd normally only get 4. But actually the patients have got longer of your time and benefiting from the other patient's experience as well. So there are things you can do, but you need support to be able to think about what you want to do and how you want to do it.
It's a great example. I'm curious if anything about patient feedback has surprised you. You've talked about how this was still embryonic, setting up some of these panels and things. Have you heard anything unexpected in that engagement?
No, I don't think anything that's unexpected, apart from, as I said at the beginning, was that we feared that patients would not respond well to you talk about a call centre and we're all horrified, aren't we? Because typically our experiences of call centres are quite poor. It's very different from a call centre, but at the end of the day, it is a call centre. We feared patients would not like that they would revolt against us removing them speaking to the receptionist that they've known for 20 years. Actually, for a lot of patients, they like not speaking to the receptionists that they've known for 20 years and who knows the rest of their family and community.
Small town New Zealand, yeah.
Exactly. And what they value most, and wouldn't we all, is that knowing that their call is going to be answered very quickly by someone who can sort them out or answer their query or put them back in touch with the practice if they need to. It's a really outdated model where you have to look at your watch, get on the phone at 8 o'clock and see if you can be the first that gets through and keep ringing and keep ringing and keep ringing. We wouldn't tolerate that in any other service that we receive, and yet we tolerate it in general practice. So I think that surprised us. And also the number of frail elderly with multiple conditions who love using the patient portal, because often what you hear providers say, oh, well, it's all well and good, all this technology, but our older patients won't want to use it. I mean, I haven't got time to tell you a whole story, but I spent one evening at a community forum we were doing with a practice that was making the change, spending 2 hours helping over 75s download the app onto their phone because they were excited about being able to email, order repeat prescriptions, and see their test results and their health record. And I think we can make assumptions about age.
No, fabulous example. So Helen, it's 2 o'clock now and we've covered the questions asked, but thanks again. I'm used to having an audience and asking them to clap, so I'm just clapping for you. But,
thank you for listening, everyone.
Yeah, thank you. It was tremendous.
Thank you very much, Helen and Leslie. That was brilliant. Thank you. And as I say, I will get the recording and slides up online as quickly as I can for people so you can view them again. Thank you.
Thanks. Bye-bye.
Bye. Thank you.